I'd like to introduce our speaker tonight. Professor Simmons is a NHMRC Leadership Fellow and Fellow of the Australian Academy of Health and Medical Sciences. He leads an international team employing Wolbachia to stop dengue transmission in the Indo-Pacific, and he's spent the last 13 years at the Hospital for Traditional Diseases in HCMC, Vietnam. And it's from seeing dengue patients on a daily basis, he says, that he draws his motivation. So, I'm really looking forward to this talk because I think this new way of treating dengue and other potentially other infectious diseases, I think is going to be a game changer and it's going to have a major impact on the entire planet. So over to you, Cam.
Thanks, Dave, and thanks to the association for inviting me. It's good to talk to a wide audience, a different audience. I'm fronting, a very large program. The overall program director is Scott O'Neill. He's based in France. We're working in 11 countries. I get the privilege of providing an overview, but this is the work of a lot of people in a lot of places over a long period of time. But this is a story about a mosquito, and this is the Aedes aegypti mosquito. It's the females that bite. This single species of mosquito is responsible for the transmission of really major medically important arboviruses like dengue, like chikungunya, and like the Zika virus. And this is a mosquito species that is the cockroach of mosquito species, incredibly well domesticated. 99% of her blood meals will come from humans. Loves to lay her eggs in human artificial containers. It loves to be where we are. It doesn't want to rest outside under a tree. It wants to rest inside in our living rooms and in our bedrooms if you live in Asia and Latin America. So this is our problem mosquito. Very different story to malaria, for example, with 45 different mosquito species that can transmit Plasmodium parasites. This is one mosquito species responsible really for 3 highly prevalent diseases.
Sorry for that. We'll have to reshare your screen again.
Oh, sorry.
No, that's my mistake.
Okay, let me go back, Dave. All good?
Yep. Okay.
So we'll just walk through, what are these diseases and why do they matter? So dengue is the most prevalent mosquito-borne viral infection globally. For most people, will experiencing an acute systemic viral infection. I've had dengue. My kids have had dengue. It's a miserable couple of weeks. A constellation of symptoms that you might expect from a systemic viral infection. And we'll talk about what some of the complications are in a moment. Chikungunya is another one. It's an alpha virus and it causes the real problem with chikungunya is not only the acute, first week of your febrile illness, but the arthralgic complications that can ensue, and sometimes for many months. And this is a relative of Ross River virus that we have in our own backyard. And then the last one transmitted by this same mosquito is the Zika virus, in which the body of literature on Zika up until 5 years ago was razor thin. And so we now know it to be the cause of in children and adults a relatively mild systemic viral infection. But if you're a pregnant woman, it's very clear that Zika virus can cause a congenital infection to the unborn baby. And the complications of that range from mild to severe. And the headline feature of Zika fetal syndrome was microcephaly. It caught the headlines in 2016 in Brazil, resulting from pathology in the brain from really systemic viral infection in the fetus in utero, particularly in the first trimester. And so there were thousands of babies born with Zika fetus with different spectrum of severity on the Zika fetal syndrome, congenital Zika syndrome. And all of those babies are going to have different levels of sequelae in socioeconomic environments where there's not a lot of support that you might find in high-income countries. And so this is the really big problem, and the reason why the World Health Organization declared the Zika epidemic of 2016 a public health emergency of international concern. This is a WHO list from 2019 that pinned dengue as one of the top 10 global health threats. And of course, it's aged a little bit in 2 years, but WHO also pinned a global influenza pandemic. It just wasn't influenza. Vaccine hesitancy was the other one. But just gives you an idea of the growing realization of the burden of dengue globally, and I'll talk through why it's important. So, firstly, where in the world are you at risk of dengue? Well, essentially anywhere where the mosquito is prevalent, and that's particularly urban environments and largely through South and Southeast Asia and tropical Latin America. We're less sure about the prevalence of dengue in Africa. We know there's some dengue in the Middle East, but sporadically. And so there's about 1.5 billion people at risk day to day of a dengue infection globally. And of course, this is a climate sensitive disease. So, and there's all sorts of reasons for that. But one of the reasons is changes to water storage practices, whether that be a consequence of prolonged droughts or other changes in the environment that result in people storing water. And that's where Aedes aegypti loves to breed, in those containers that people store water in. Just want to talk about the clinical problem and the public health problem. And I said, for most people, it's a 1 to 2 week illness. It's a miserable week. It's really quite painful. The headaches, the muscle aches. It was called breakbone fever 300 years ago for a reason. It's particularly painful. But I just want to draw your eyes up to this middle bubble chart, and you can see there's a group here called dengue with warning signs, and that's a set of laboratory changes and clinical changes that in some patients result in severe plasma leakage. So leakage of your water and small molecules into your interstitial spaces. In some patients, severe hemorrhage, particularly through mucosal sites. In some patients, severe organ impairment. So an encephalitic syndrome, hepatitis, renal dysfunction. And so, but the really big one is really this plasma leakage syndrome that is more common in children and is life-threatening and can result in a syndrome called Dengue shock syndrome that is, that kills around 20,000 kids every year globally. And why is all of that important? Well, the problem of dengue is not the 20,000 deaths a year. It's the burden of dengue. So if you live in Southeast Asia, by the time you're 20 years of age, you'll almost certainly have been exposed to a dengue virus. That's the force of infection. You're really trying to, walk through rain without getting wet. If you live in an urban area in Southeast Asia or Latin America, and the problem is that these outbreaks of dengue, whilst there's always dengue every year, it's usually seasonal in the rainy season. And every 3 to 5 years, there's a big outbreak, and that floods clinical services. So on the left, you can see parents who are sleeping on the floor in the corridor at the Hospital for Tropical Diseases in Ho Chi Minh City. The bottom right's the outpatient department. When things are bad, it's 2 patients to a bed. And so the clinical challenge is that you're not sure which patients are going to develop complications, which typically happens around day 5 to 7 of the illness. And so a lot of patients get admitted for careful observation. And so it puts a huge burden on the healthcare system. So what have we got to fight dengue? There's one licensed dengue vaccine from Sanofi Pasteur, but it's not used programmatically. And it's because it's a complicated vaccine to deploy with a particular safety profile, particularly if you've never had dengue before. We don't have specific antivirals, so we can't, there's no specific drug to stop virus replication. And correspondingly, there's no drug we can give you to prevent you getting dengue in a chemoprophylactic type of way. What has been the mainstay for dengue control is targeting the mosquito vector. And of course, many of you know what that looks like. And this is what it looks like. Fogging in the community, which is targeting, putting out a pyrethroid usually, or sometimes an organophosphate-based insecticide out into the environment. The problem is that where they're spraying here is not where the mosquito is. The mosquito is tucked away inside in a living room. More space spraying, sometimes efforts around larviciding, breeding sites, but not everyone wants public health actors dropping larvicides in their water or their washing water. No one wants this guy on the right-hand side inside their house. And so you've got this mismatch between municipal services, cities. They want to be seen to be doing something, and this is what they do. But there's this great big mismatch around where the actual vector is, and these are just some key attributes of the mosquito that I've already told you. That this is a cockroach. It loves us. It loves to live in amongst us. Will be found inside homes. A really good vector of this virus, because to complete one reproductive cycle, she will often take multiple blood meals, and sometimes from different people. And so that process of sort of promiscuous biting, a little snack from 2 or 3 people in a house, is a great way. Is the perfect job description for a good vector. So what are we doing about it? So our solution is targeted to this mosquito, but we're not about suppressing the mosquito population. We're a biocontrol program, modifying the mosquito population with a bacteria. And the bacteria, our intervention, our product, if you like, is this intracellular insect bacteria called Wolbachia. And Wolbachia is probably the most prevalent intracellular bacterium on the planet. You can find it in many places. Up to 60% of all the insect species in a given country will have a Wolbachia infection. Okay, so it's hugely prevalent through the insect population. It's probably a global pandemic of Wolbachia going on, that if you came back in 1,000, 10,000 years, you'll find another 10% of insect species have got Wolbachia. But it doesn't naturally exist in Aedes aegypti mosquito. It hasn't got there yet. It does exist in other mosquito species that bite humans. And on that basis, we've got high confidence that it's not a pathogen of humans, and high confidence that it's not a pathogen of animals. Indeed, it can't replicate at 37 degrees. So really high confidence that this is not, it doesn't have a risk profile that would be concerning. But the remarkable thing that my colleague Scott O'Neill discovered nearly 15 years ago was that if you put Wolbachia and you set up a stable transinfection of the Wolbachia bacteria in the Aedes aegypti mosquito, is that Wolbachia pretty much puts a stop sign up in the mosquito's tissues, so that these medically important viruses like dengue, Zika, chikungunya, and even yellow fever don't replicate as well, don't replicate anywhere near as well when compared to a wild type mosquito. And just to go back a step, how do we get Wolbachia into the Aedes aegypti mosquito? Well, this was painstaking work of taking a Wolbachia bacteria from Drosophila melanogaster, the fruit fly. You can find it buzzing around your bananas. This is the Wolbachia bacteria, this intracellular bacteria you'll find in these Drosophila cells. And essentially what the program did was make a homogenate of these, basically of ovaries from fruit flies, and micro-injected it into 1-hour-old Aedes aegypti eggs. And so you can see that process down here. Now, most of the time this fails. The egg dies as a consequence of trauma. Most of the time, Wolbachia fails to infect the germline cells in the egg. But occasionally, very rarely, in fact, it takes thousands and thousands of goes to achieve this. You generate a stable Wolbachia infection in a female Aedes aegypti, and that's the Eve mosquito, because all of her offspring have also got Wolbachia. So you only need to achieve this once. And this was achieved with the WML strain. WML stands for the melanogaster side of our Wolbachia strain. And so that's how it was set up in the first instance.
Cam, what does the name Wolbachia mean, and where did it come from?
Look, so Wolbachia was sort of discovered. I don't know I confess I don't know the origins of Wolbachia, but discovered in the 1920s in flies, and there's a whole discipline around Wolbachia, and particularly its ability to manipulate phenotypes in insects. And we'll touch on what some of those phenotypes are in relation to how we work. But I'm going to let Bill explain a little bit about how we operationalise Wolbachia as a public health tool.
Dengue is actually one of the few diseases in the world that's getting worse all the time. Although some people are working on vaccines or drugs, we have none. The Dengue project is a kind of amazing thing where they're putting a bacteria called a Wolbachia into these mosquitoes that prevents them from transmitting this terrible disease. If you release the mosquitoes that have this bacteria and then they mate with the other Aedes aegypti mosquitoes, it spreads this Wolbachia that blocks the disease. Yeah, in a way it sounds pretty simple. So you'd think, okay, we just grow a bunch of mosquitoes, we go out and release them. Well, in fact, getting the community to be comfortable with the idea that you're actually putting mosquitoes into the environment, what does that mean? It is a natural bacteria that's being used, but even so, they reach out to the community and talk to them. If things go well in these small pilot areas, then in 2016, they'll take this whole city here, which is about 400,000 people, and do that for a couple of years. And if that goes well, then they'll take a really big city like Rio de Janeiro, Jakarta, Ho Chi Minh City, all cities that have growing dengue burdens, and go and do something really large scale where the health benefits would be big. All these things we work on require a lot of patience and a lot of learning. This is one that, I think it's at least halfway there and has a very high chance of success.
So Bill kind of got the science right, and let's just sort of revisit the science a little bit. And just on this slide, I just want to talk about how we think Wolbachia works to block these viruses from replicating in mosquito cells. And this big circle, just imagine that's a mosquito cell. It could be a cell in the midgut of the mosquito, or of the wing muscle, or importantly, in the salivary glands of the mosquito. And so the virus wants to go in, the dengue virus wants to go in, goes into this endosome, and then in a low pH environment, the viral RNA goes into the cytoplasm, and then it wants to replicate itself or translate itself and then replicate itself with its own polymerase. And then what it really relies on, these viruses are renovators. Okay, these are great DIY renovators, these viruses. They want to go in, change the organelle structures, the environment, the flow of resources inside the cell to favour their own replication, particularly in these what we call vesicle packets around the endoplasmic reticulum that I'm sort of showing, hopefully you can see in my cursor. But in the way is this green, you can see this sort of green, rods like here. Well, that's Wolbachia. That's where we think Wolbachia is sitting. We know microscopically that's what it's doing. And it's kind of like you've gone to Bunnings and bought your paint and your paintbrushes. You've come home to paint the bedroom, and actually you found a professional painter in the room already, and he or she's done the job already. So Wolbachia is there first. It's blocking the ability of the viruses to renovate inside the cell in the way that it needs to replicate itself efficiently. And that process is really a syndrome inside the cell. We think there's lots of mechanisms going on here that interrupt the natural history of virus replication. And that may resonate, because that means the virus, to evolve resistance, might need to do lots of different workarounds to escape that antiviral state created by Wolbachia. And just to illustrate again, a Wolbachia infection is a systemic infection of the mosquito. And so just up in this top right, you can see the ovaries. The ovaries are, richly infected, because Wolbachia really just wants to look after itself and get transmitted to the next generation. But as a byproduct of a new infection in this species, you can also find this green shading. You can see this is where we find a lot of Wolbachia in different parts of the anatomy of the mosquito. And a pretty important part is that we find Wolbachia in the salivary glands, these globular cells that are responsible ultimately for hosting virus replication in those salivary gland cells and for virus to appear in the saliva of the mosquito when she takes a blood meal. And that's the basis of transmission. Having Wolbachia in the salivary glands may well prevent, we believe, we've got data that shows that Wolbachia in the salivary glands is putting a dampener, that red stop sign, on the virus's ability to grow to a high enough titer in the salivary glands. And what that means is that the mosquito is much less infectious when compared to a wild type mosquito. So Wolbachia puts a stop sign against the virus. The other great trick that allows us to operationalize this as a public health tool is that Wolbachia manipulates reproductive outcomes so that you can establish Wolbachia into a mosquito population off the basis of a small number of mosquito releases of mosquitoes containing Wolbachia. And the trick is that Wolbachia manipulates these reproductive outcomes. And I'll walk through these. And this mating outcome A is a male Wolbachia infected mosquito mating with a wild type female out in the field. And he sterilizes her because she will only mate once in her life. And if that first mating event is with a Wolbachia infected male, she doesn't produce any viable eggs into the environment. These other alternative mating outcomes are Wolbachia infected male mating with a Wolbachia infected female. All of her progeny, all of her eggs have got Wolbachia, and all of those will emerge as adults with Wolbachia. A Wolbachia infected female, when she mates with a wild type male in the field, all her progeny will also be viable and have Wolbachia. And so you can imagine over the course of weeks and months that the outcome of these mating events results in steady introgression of Wolbachia into a field population of Aedes aegypti mosquitoes. And so what do we do in practice? Well, we can go to Jakarta or Ho Chi Minh City, where there's a standing population of wild type Aedes aegypti. It's very good at transmitting dengue or Zika or chikungunya. We typically go along for between 10 to 20 weeks in a fairly spatially homogeneous way through the community, through an urban environment, and release Wolbachia infected mosquitoes. So counterintuitively, we're targeting a vector-borne disease by release of mosquitoes and using this biocontrol tool of Wolbachia to not suppress the mosquito population, but to change their permissiveness for virus transmission. And so we don't need to release our Wolbachia infected mosquitoes until 50% or 100% of the population's got Wolbachia. We can stop the Wolbachia releases at around 30%. So when we go and catch back mosquitoes from the field, if about 30% of them are Wolbachia infected after 10 to 15 weeks of releases, we're getting pretty relaxed, pretty comfortable, and thinking we can begin to stop releases in this community. And Wolbachia, because of those mating outcomes, will gradually introgress into the population until such time. This can take 12 months. 90 to 100% of the mosquitoes have got a Wolbachia infection in that given community. And we can release mosquitoes as adult mosquitoes, or we can release them as eggs, and there's pros and cons to each. And so I've told you about these three traits: Wolbachia putting up the red stop sign to the virus, Wolbachia being vertically transmitted to each new generation of mosquitoes, and this process called cytoplasmic incompatibility, manipulating reproductive outcomes to get introgression into a population. And so we as a program are operationalizing that as a public health tool. So really Wolbachia for biocontrol of these diseases. And we're working in 11 countries. We're not for profit. Originally, really an international academic consortia, but increasingly with NGO partners and with governments and other civil society groups at the table working with us and partnering. These are the places where we work. And so our work, really the sandpit, if you like, the first open field releases occurred in North Queensland in 2011, and I'll speak to that. We've had a lot of joy working in the Western Pacific over the last 5 years. Been working in Indonesia, particularly Jakarta, for 9-10 years now. In Vietnam, it's a decade of work, 3 years in Sri Lanka. The program's been active in Brazil and Colombia for 7 or 8 years, and in Mexico for the last 3 years. So we've got a wide footprint in all the places where dengue has a really big impact on public health.
I've just had a chat message, and I'll invite listeners to put in their questions through the chat function. But just to say that Wolbachia was named after Simeon Burt Wolbach.
Yeah, Burt.
That's according to Wikipedia.
Absolutely, yeah, that's spot on, and thank you for that. I just want to talk about how we release mosquitoes, because I think it's important to think about for the long-term future of this intervention. So this is in Rio, Brazil. So releasing mosquitoes at the side of a car every roughly 75 meters. This is in Colombia. This is the start of a release period, so kind of bespoke mosquito releases. These are adult Wolbachia infected mosquitoes, and this is Vietnam. And so we can release adult mosquitoes, and we're trying to innovate. How do you do scaled delivery of adult mosquitoes? And we've been working with an NGO partner who's really an engineering NGO, and we've been looking at the ability to deliver Wolbachia infected mosquitoes by drones. So you can see here, this is a pilot site near in Nassori in Fiji, near the airport in Suva. So we did a 1 square kilometre trial of the release of sleepy Wolbachia infected mosquitoes from this drone that covered the landscape about 50 to 75 metres up in the air.
UAV has a lot of potential. In our ground releases, we can only release in areas where we can access it by vehicles. But with this UAV, we can access those difficult areas.
It's a success because over the weeks we have seen through our monitoring, then the percentage of Wolbachia has always been increasing.
So just pause there. So in that esky is a relatively simple but at the same time elegant mechanism that aliquots out from a pool of about 250,000 asleep Aedes aegypti mosquitoes. They're asleep because they're sitting at about 5 degrees. That aliquots about 150 adult mosquitoes out the bottom of that ejector, at the bottom of that mechanism as it flies across the landscape. And so we're interested in exploring, yes, the UAV, the drone is, attractive, edgy, but that mechanism could be on the back of a bicycle, could be on the back of a pony, it could be on the back of a motorbike. And so we're interested much more in the actual optimizing the mechanics of the mosquito releases to deliver a high quality product into the community at scale. So I'll just touch on egg releases as well. It's the other method of deploying the Wolbachia infected mosquitoes into the environment. And this is in Indonesia. This is an older method in which what you saw there, and I'll just actually take it back. On those orange strips are about 200 mosquito eggs, where the mosquitoes laid the eggs in a cage in a laboratory essentially. And so what our team member there is doing is putting that strip of eggs, 200 eggs, with a few pellets of fish food, essentially food for the larvae as the eggs hatch, and the adult mosquitoes will emerge out of these plastic buckets into the environment. And so there's a number of advantages to the egg-based release method. It's easier to get the community involved in the last mile deployment of the intervention. It's easier to control the product, if you like, out of the factory door. And so there's a number of just sort of, as we go to industrializing the process of making mosquitoes at scale, there's a lot of attractive features to making using eggs as the product that goes into the field. And so, here's another example of as we mature and industrialize that mosquito manufacture. And so what you're looking at here is really gelatin capsules, very similar to a paracetamol capsule that you'd buy over the counter. Same thing, same principle. Gelatin will dissolve in an aquatic environment. And just to go through this video here, this is a gelatin capsule in which there are a few hundred mosquito eggs together with some food, some diet for the mosquito larvae, a little bit of charcoal as filler. An hour or so, the gelatin capsule dissolves. And then over the following hours, you get hatching of the mosquito eggs. They've got food in that environment now. And so what you get is over, a 7 to 12 day period, the emergence of adult mosquitoes as a consequence of, hatching that capsule in a water container. So what I'd like to do now is just talk about, so I've given you an insight, basic mechanisms of how the intervention works, a bit of a snapshot of how we deploy it into the field. And all that's great, but what about the public health outcomes? And so the next little piece speaks to that. The first deployments and establishment of Wolbachia was performed in North Queensland in two suburbs, one called Yorkeys Knob, just north of Cairns, and another in Gordonvale, south of Cairns. 2011, we established Wolbachia in those small townships. And then over a period of 5.5 years, we, in a step wedge fashion almost, deployed Wolbachia through the rest of the communities in far North Queensland that have historically been impacted by dengue transmission. And so everywhere from Port Douglas, from Mossman, down as far south as Charters Towers, we've deployed Wolbachia into the local Aedes aegypti mosquito populations. And why did we do it? Because dengue's been a public health problem most years in far North Queensland for at least the last 20 years. And dengue is not endemic in far North Queensland, but what happens is that travellers coming usually back from Bali or Thailand or somewhere else in Southeast Asia, viremic dengue travellers come in, get bitten by a local wild-type Aedes aegypti mosquito, and that's the spark that lights the fire of a local dengue outbreak. And so every year, public health teams have been responding to dengue outbreaks in far North Queensland for the last 15 years. And so since we've deployed, I think rather than the data, I think the best testimony to the public health outcomes is Richard Gare, who runs tropical public health services in Cairns and has spent last 20 years of his career, mostly fighting dengue outbreaks every wet season. But their testimony is that really dengue's disappeared. Local dengue transmission has disappeared in communities where Wolbachia has been established, despite pre-COVID, this incoming sparks from viremic travellers continuing to come into North Queensland, being detected through clinical services, being diagnosed as an imported dengue case. But those local outbreaks driven by those importations are not happening anymore. And so far North Queensland's delighted, and in fact we've assisted them to do deployments of Wolbachia into Cape York, the northern peninsula area, into Ingham, and continue to talk to Queensland Health about new communities that might benefit from Wolbachia in places like Bowen and the Airlie Beach area. So really good evidence from Australia of growing evidence of impact, but the World Health Organization is the technical gatekeeper in this space. So to get a World Health WHO recommendation for this intervention, you really need to demonstrate high quality evidence, entirely appropriate. Historically, in vector control interventions, aside from bed nets for malaria, very, very few randomised controlled trials targeting Aedes aegypti mosquitoes, and lots of reasons for that, but very, very few performed. But WHO requires, before WHO will get behind and say there's robust, sound evidence supporting a particular intervention, they require at least one randomised controlled trial. And because our intervention is deployed at the level of communities, not at the level of individuals, that requires cluster randomised controlled trials. And so this was our goal really 5 years ago, to go about delivering at least one randomised controlled trial in a dengue endemic setting that demonstrated public health impact. And we did that in Indonesia. We did that in the city of Yogyakarta, and we worked with colleagues at the University of Gajah Mada. And we began working with those colleagues in 2012 with initial pilot studies and baseline work, and leading up to a randomised controlled trial that began in 2017. This is Yogyakarta, densely urban population. It's about 26 square kilometres in this space here in the city itself. But obviously there's an urban sprawl that extends outside the city boundaries. Endemic for dengue for the last 20 years, usually in the top 10 for disease burden, for the dengue disease burden in Indonesia. And just to demonstrate, densely populated urban environment, a haven for Aedes aegypti. By the time you turn 10 years of age in Yogyakarta, about 3/4 of children had had a dengue virus exposure. So a high force of infection. And so this 2.5 minute video just captures what we did and captures some of the key outcomes of the trial. It underplays a huge amount of work from our team, from our colleagues at the University of Gajah Mada, and a huge contribution from the local community in agreeing to participate in a citywide randomised controlled trial, agreeing to consent to randomisation at a community level. And so that itself is quite remarkable, particularly in an urban setting. And so just listen, you'll see the key highlights towards the end, but hopefully this unpacks what we delivered in that cluster randomised controlled trial in Indonesia.
Mosquitoes are very good at spreading disease, transmitting viruses from one human to another. Some of the diseases they spread, like dengue, can be deadly. But researchers at the World Mosquito Program discovered that when they infected the dengue mosquito Aedes aegypti with a bacterium called Wolbachia, the mosquitoes are much less likely to spread disease. To prove this theory, we work with our friends at the University of Gajah Mada and the government and people of Yogyakarta, Indonesia, where dengue is a serious problem. Together, we designed a gold standard randomized controlled trial, or RCT. 12 areas of the city were randomly selected to receive Wolbachia mosquito releases, alongside routine dengue control measures. The rest of the city will continue with just routine dengue control measures. Over several months, with the help of the local community, we released Wolbachia-carrying mosquitoes within the 12 selected areas. These mosquitoes spread with the local wild mosquitoes until nearly all mosquitoes in the 12 areas carried Wolbachia. Then, we began to monitor the number of cases of dengue throughout the city. If patients presented with signs and symptoms that could have been dengue, with their consent, we recorded where they lived, where they traveled, and tested whether they had the disease. Over 27 months, we found that the incidence of dengue was 77% lower in the areas treated with Wolbachia, and the effect was consistent across all 4 dengue virus types. Importantly, dengue hospitalizations were reduced by 86% in the Wolbachia-treated communities. The people of Yogyakarta were excited by these results. So excited, they have now expanded the deployment of Wolbachia mosquitoes right across Yogyakarta city. Over the next 10 years, we estimate this will prevent tens of thousands of dengue cases, avert millions of dollars in healthcare and societal costs, and stop children missing out on thousands of school days each year due to dengue illness. The World Mosquito Program plans to implement the Wolbachia method all over the world. Our success in Yogyakarta is just the beginning.
So just to repeat, the headline numbers, 77% reduction in this randomised controlled trial against virologically confirmed dengue, 86% reduction in dengue hospitalisations in Wolbachia treated clusters in the trial. You can read all about it with my brilliant co-authors, Katie Anders, Adi Uttarini and Chitra Indriani in Georgia, published a few months ago in the New England Journal. And so that's great. Our trial, really profound, the most profound impact of any vector control trial against this mosquito, against a clinical outcome, against an epidemiological outcome, relevant public health measures. But another critical ingredient to the ability, or the likelihood of this intervention being mainstreamed as a tool in the toolbox of public health is how much does it cost, and is it cost effective? And so this is not our work, but the work of independent academics at the London School, who firstly estimated that Indonesia has Indonesia's a big country, has around 7 million dengue cases a year. And that has a cost to Indonesia of $1 billion every year, with most of those cases sitting in the big cities. And what they did was to predict that an investment of about $300 million in 7 big cities, highly endemic for dengue year after year, could avert 1 million dengue cases and save 500 lives every year, pay back the investment, the upfront cost of putting Wolbachia into those cities, pay back that investment 2 to 3 times over a 10-year period. And that's just the dengue piece. But you're also buying insurance against outbreaks of Zika, chikungunya, and less likely yellow fever. And so the health economic case is really robust in urban environments where really you're, if you like, immunising the landscape. And so the more people you have per square kilometre of an urban landscape, really the cheaper per person the intervention becomes. And the really critical attribute of this intervention is you only need to do it once up front. It's like a piece of public health infrastructure that you set up once, like building a bridge or building a road. If you put up Wolbachia into the mosquito population, we know that Wolbachia is going to persist in those mosquitoes for many, many years. And North Queensland, it's been a decade without the need to re-release Wolbachia mosquitoes. And this is what Wolbachia does. Wolbachia's job description is to, once it's in an insect population, to stick in that population, for thousands of years. And so we've got this bold ambition of protecting 75 million people over the next 5 years, and 2025 comes around very quickly. This is our footprint of where we work. We're getting good traction in Latin America, in big cities like Rio de Janeiro, like Medellin, starting to get scale in Vietnam, starting to get scale in Indonesia, where you've got these densely populated urban areas. This is how we're tracking. This is number of people where we've deployed Wolbachia into their community. This is in millions of people. This is time along the x-axis. And you can see we're getting close to 8 million people protected globally with Wolbachia deployments. A lot of that has been in Latin America because of the work in the big densely populated cities of Rio and Medellin. And we're at about 1,000 square kilometres of deployment area. And so the last slide, how can you help? And so go to our website. There's lots of ways of helping our program in kind, through networks, through connections to civil society groups in our region or globally, or good old cash enables Wolbachia to find more communities. And so we are a not-for-profit. We're incredibly grateful to our donors, the Bill and Melinda Gates Foundation, the Wellcome Trust, the Gillespie Foundation, and many others, the NHMRC in Australia for foundational work. Many wonderful partners around the world. We only work through partnerships, academic, NGOs, government partners, civil society groups. And so we're very proud to have launched this Australian science in a global way, but we still have a long way to go. And we're going through that valley of death at the moment, if you like, as COVID grabs everyone's attention. But in the background is this grumbling global pandemic of dengue that's been unaddressed for the last 50 years. And so I hope I hope I've told you a compelling story of a Australian-made biocontrol tool that we think can bring about really profound long-term public health benefits to communities who need it in Asia and Latin America.
That was absolutely tremendous. Now, there are a number of questions that have been put on the chat function, so I'll pass them on to you. But before I do, as well as thanking you for a wonderful talk, I'll take Chairman's privilege and ask the first question is, so mosquitoes and infectious disease, of course you think of other diseases such as malaria. Now, is there a possibility for Wolbachia to treat other diseases in addition to chikungunya, yellow fever and dengue?
Yeah, so the upstream science has been done, and so look, I think that the bottom line is that the evidence of Wolbachia blocking the Plasmodium parasite is not as compelling as it is, and that's explained in part by the biology of where the Plasmodium parasite is inside the mosquito and these viruses that are strictly intracellular, and so I think there's not enough robust or compelling evidence that this is going to be a tool for malaria, and also that caveat of you've got a number of different anopheline species that'll transmit malaria. So you need to set up these Wolbachia infections in a variety of mosquitoes to have a global approach to it. Yeah,
can Wolbachia be modified so that it alters its function so it can combat a wider variety of parasites?
Yeah, it's been a bit of a PhD killer though, Dave. So really hard. No one's cracked the nut of manipulating Wolbachia. So there's a treasure trove there waiting for someone clever enough to solve that problem. We can't grow it in vitro. We don't have tools to manipulate it.
So somebody's asked, what is the radius of movement of mosquitoes, i.e. when you release in a particular spot, how many do you infect? Hundreds of square kilometres, or what's the radius?
Yeah. So I give this metaphor, this analogy of my teenage daughters on a wet, rainy Melbourne day, and if they've got food and internet, they're not going very far from the couch. And Aedes aegypti, if you release 100 female Aedes aegypti in a house in Yogyakarta, maybe 5 will leave the house. And probably none of them will fly more than 50 metres or 100 metres in their lifespan. So we need to deliver Wolbachia to the mosquitoes. We can't. Spread is too slow to achieve that. Yeah, they're pretty lazy.
What are the routine dengue control measures employed in Indonesia, and will they interfere with the spread of Wolbachia?
Yeah. Look, and I think it's a testament that how ineffective standard of care control tools are, that they have no impact on our ability to establish Wolbachia into a mosquito population. Spraying is typically highly reactive and typically too late. So that by the time public health services are out and responding and spraying, the actual infection event and that mosquito that probably happened 2 weeks ago. And so it's all in places like far north Queensland and southern USA, that when they do it at scale, they're starting from small focal source outbreaks. But when it's endemic and you've got multiple fires going across your city at the beginning of every rainy season, it just doesn't work. And that's the epidemiological evidence that dengue hasn't gone away.
Are there any plans to have programs in Africa?
Yeah, we're exploring Africa. I think the great challenge is to understand the disease burden. And so I think there's urban communities in Western and East Africa where there's good evidence of dengue transmission. Is it the biggest clinical challenge burden? Is the most important public health problem? Probably not. And so it's a conversation with donors and governments around is this the right tool at the right time for them?
And could a mosquito evolve to become resistant to or fight off Wolbachia? I guess a related question is, why don't all insects, why aren't they all full of Wolbachia?
Yeah, so very good question. My guess is that Wolbachia, this new infection in Aedes aegypti will attenuate over time. But our, the evidence, what we understand about other, fresh infections in insect species, that can take hundreds or thousands of years. So I think we've got a window in which the Wolbachia is a systemic infection in the mosquito, and that looks really stable and really solid after a decade in the field. So we're pretty optimistic we're going to buy at least decades and probably longer of protection. If you come back in 10,000 years, Dave, you might find another 10% of mosquitoes infected globally. So it's just a rare horizontal, transmission event that over evolutionary time is slowly working its way through insect species.
A Wolbachia related to rickettsia and
right.
so other sorts of intracellular.
Yeah, it's really cool. Alpha proteobacteria. Yep.
All right, then I think it's time to wind up the talk with